Hello, and welcome to the Clinics Review Articles podcast. Thank you for listening. I'm Stacy Eastman, the managing editor for Neurologic Clinics here at Elsevier. The series is a quarterly publication consisting of review articles centered on a key topic of interest for practicing neurologists. In today's podcast, we will be discussing our August 2017 issue of the series, which focuses on sports neurology. Joining me for today's talk is the issue's guest editor, Dr. Tad Seifert. Dr. Seifert's affiliations include Director, Sports Concussion Program, Norton Healthcare, Neurologist, Norton Neuroscience Institute, Team Neurologist, Western Kentucky University Department of Athletics, Chairman, Kentucky Boxing and Wrestling Commission, Medical Advisory Panel, Association of Boxing Commissions, Medical Committee, and Head of the NCAA Headache Task Force, Norton Healthcare, Norton Neurology Services, St. Matthews, and Louisville, Kentucky. Welcome, and thank you for joining me today. To start off, it would be great if you could tell us a little bit about your goals and vision for this issue of Neurologic Clinics on sports neurology and what went into planning it.
Sure. I was approached to serve as guest editor for an issue dedicated entirely to sports neurology. And sports neurology is a topic that's near and dear to my heart. I got into sports neurology really from the headache medicine side of things. I did my residency and fellowship in Houston, Texas, and I did my fellowship in headache and facial pain at the Houston Headache Clinic. And there, my mentor was Ninan Matthew, who was just a great man, and I learned really everything that I know about headache from him. And fortunately, during that year of fellowship, I also was exposed to sport neurology simply because he took care of a lot of the Houston area athletes when they sustained concussion or when they had difficulties with persistent post-traumatic headache or post-concussive headache. And it was really then that I knew that I could merge my two interests together, being headache neurology as well as sports neurology. And subsequently, that's how my practice has evolved over the last decade to where currently probably about 90% of my practice anymore, my outpatient practice, is sports neurology, of which a significant component of that is sport concussion. And just because of my exposure to the field, and I've been very fortunate and lucky and been able to contribute a little bit to the field in the form of publications and literature. I was approached to head up this project, which was Neurologic Clinics, look at sport neurology and dedicating an entire issue to that. The last time that they had done a sports neurology specific issue, I believe, was 2008. So it's been about a decade, and this field continues to evolve and emerge and change on a monthly, if not weekly basis. So certainly it was time to update what we had present in the literature through the lens of Neurologic Clinics. And I was approached to do that about a year and a half ago, and subsequently identified individuals that I highly respect within the world of sport neurology to help formulate what ultimately became this issue.
Great. And in your preface, you know that there is no other medical discipline where knowing the patient is so imperative to ensuring recovery. Could you touch on that a bit?
There's a big difference in how we approach caring for the athlete versus how we approach caring for the layperson. And no one approach is more important or less important than the other. It's just very different. Knowing the athlete population, this is a population that often wants to get better too quickly, and that's a pro and a con. And really being able to be around these student athletes or these professional level athletes and knowing their baseline is just absolutely imperative, because that is where we always will have hopefully a solid reference point to be able to look back at their history and to, number one, ensure ourselves and them and everyone involved that they are indeed back to their baseline after they've gone through whatever medical issue is that they've incurred. And also is just with any other type of medicine, what you take into the injury certainly affects how your recovery goes and how you look coming out of the injury and all of the potential challenges that were faced during that recovery time period. And I think that is more so true for sports medicine than any other discipline. And invariably there are challenges and there are changes that have to be made as we rehabilitate these athletes, and knowing them and knowing them well, I think does nothing but serve as a positive for us, the clinician that's trying to help them through this injury.
Okay, thank you for that background. Let's dive into the first article that we are going to discuss today, which is on the current state of sports concussions by Drs. Jana K. Register-Mahalik and Melissa C. K. Although there are varying definitions of concussion, what are some basic components?
Yeah, probably the most widely used definition is the one that's used by the concussion in sport group, and that's the consensus statement that comes out of the concussion in sport group that meets every 4 years. Most recently, it met in Berlin in the fall of 2016, and the new consensus guidelines were just published in the British Journal of Sports Medicine this past spring. And every definition of concussion has its similarities. Yeah, it's without question it's a complex injury. It is more of an injury of function rather than structure, meaning that on standard neuroimaging studies like CAT scans or MRIs, there is not an identifiable abnormality. Meaning this is more of a injury of function rather than structure. It's a transient injury, meaning it has a beginning and an end. It induces some type of neurologic dysfunction, which can manifest in many different ways clinically. It does not necessarily have to involve loss of consciousness. In fact, a far majority of concussions do not. It's really a complex manifestation of different types of symptomatology, from physical symptoms to cognitive symptoms to balance and motor difficulties and everything in between. So it's really a spectrum, and it's a syndrome, so to speak, rather than one distinct clinical entity.
Thank you. And could you take us through best practices in concussion management and potential long-term implications of concussion?
Sure. Yeah, and that's where I thought the authors of the current state of sports concussion did a really good job outlining this. Dr. Jana Register-Mahalik from the University of North Carolina and her co-author, Melissa K. One thing that I really liked about their publication was the fact that they did discuss the cumulative and long-term effects from concussion. Yeah, and we all, when we think of that topic, we think of the actual recurrent concussion itself, but they also delve into somewhat the effect of the subconcussive impacts, which we're now starting to see from an empiric scientific basis, that arguably is just as injurious, if not more so, than the actual clinical diagnosis of concussion that's made, on the sideline or in an outpatient training room or in a clinic setting. And by subconcussive impacts, we mean those injuries or those impacts that do not meet threshold to cause a true diagnosed concussion, but yet these are still injuries that likely still cause alteration in the neurometabolic cascade, just not to the same extent of what you consider a true quote-unquote concussion. And these subconcussive hits, when they are experienced in a cumulative manner, can still cause potential long-term neurocognitive deficits and potential neurodegeneration.
And there was a statistic in the article that concussions account for approximately 10 to 15% of all sports-related injuries. And I know that there are current policies aimed at reducing the frequency of head impacts. What are some best practices that can be taken to help prevent these injuries?
Yeah, that's a good question. And when you really step back and look at the bird's eye view of the problem, yeah, a good example is the legislation that's now in effect in all 50 states with regard to high school and youth level sports, where if a concussion is suspected, the athlete has to be removed from play and evaluated, and if concussion is subsequently confirmed or diagnosed, then they have to be removed from play, and permanently so until they are seen and cleared by a medical professional. This serves a very important purpose, specifically to get that athlete out of further contact risk activity, because we know that when an athlete sustains a second concussive impact on top of an initial injury that is not yet healed, number one, the effects can be catastrophic. Although that's unusual and rare, it can happen. But more importantly, what we're trying to avoid is the chronic, unrelenting, very difficult, prolonged recovery course that can and often does occur when second injury occurs on top of a initial injury, before that initial injury has healed and returned to baseline.
Are there any other key takeaways from this article on the current state of sports concussion that you would like to touch on today?
Yeah, I thought they really did a nice job of just highlighting and stressing the fact that approach to concussion really is a multimodal process, meaning that there are a number of individuals involved in concussion. Not only the individual that sustained the concussion, but also educators, also parents, coaches, other teammates, and furthermore, in a number of patients, an approach has to be taken from a true multimodal angle, meaning that athletes should be addressed not only with the symptoms that they are experiencing, but also we have to take into consideration other aspects of their life, their academic challenges that they invariably face on many different levels, the social impact that the injury often incurs by taking them out of their circle of friends or their normal level of social structure. And it's really not until you approach the injury from all of these different angles of potential treatment and intervention that you get the most optimal result and recovery.
The second article we will be discussing today is Sideline Sports Concussion Assessment by Drs. Kenneth Pottle, Chris Presley, and Howard Derman. I know that the sideline concussion assessment tool is in revision and that it's the standard of care in sideline concussion assessments. Can you talk about this tool?
And I believe what you're referencing is what's called the SCAT, and it's the current version is the SCAT-5, the Sideline Concussion Assessment Tool. And the SCAT-5 has come about from this most recent consensus statement, that the Berlin statement that was published earlier this year that I referenced previously. And as the science continues to evolve, so do our evaluation tools. And the SCAT-5, when you look at that specifically in reference to the previous version, which was the SCAT-3, the SCAT-5 now has an expanded demographic section. Specifically, there's more of a detailed history that's obtained, pertinent to the patient's prior concussion history, as well as their prior neurologic history in general, like history of migraine. There is a new and expanded 10-item word list that we used for immediate word recall and delayed recall. The neurologic exam that is a component of the SCAT-5 has also been expanded to where we now look specifically at neck range of motion. We also look a bit more expansive into vestibular ocular, gait, and cerebellar testing. So the SCAT5 is a tremendous tool that we will commonly use, either on sideline or in the outpatient evaluation of an athlete with sport concussion.
And the authors do a nice job outlining some challenges when it comes to assessing sideline concussions. Could you please walk us through some of those challenges?
The challenges are numerous, and these include the fact that, number one, players often underreport concussion. These are individuals that are highly competitive, and either they, number one, themselves don't want to remove themselves from play, or they feel pressure from teammates or coaches to remain in play. Another challenge is that, in the injury of concussion, this is a neurologic injury where individuals are often impaired, and they may truly not realize that they are injured. So, we're trying to evaluate and to reason with an athlete that they should not return to play when the individual, in and of themselves, they are impaired. Another challenge is that, as I'd referenced previously, most concussions don't involve loss of consciousness or other pathognomonic neurologic signs or symptoms, and that's still a big misconception in the lay public, that a number of people still think that you have to be knocked out to have a concussion, and that's just simply not the case. Another challenge is that there's no one single objective test that we can use on the sideline to say, yes, you are concussed, or no, you are not. And I had referenced the SCAT5 as a very useful tool, which it is, but even the SCAT5 has its own limitations. So bottom line is there's no one single tool that we can use to say, yes, you are ruled in, or no, you are ruled out. And all of these are challenges to us. The final challenge that I would reference is just simply the time limitation that sometimes rules of sport incur on the clinician trying to make this judgment call. For example, in FIFA level soccer or football, as it's referenced in European countries, there is allowed an on the pitch or on the field 3-minute evaluation to make the determination of whether that player has sustained a concussion or not. And under FIFA rules, once a player is removed from play, they cannot return to that same game. There aren't rules of substitution like there are in other sports. So this is a big call that has to be made by medical professionals at that time within a 3-minute window, which is often very, very challenging.
And I think it's important to note, as you touched on, that an athlete may have a concussion even if their SCAT is normal, and that there are some additional tests that may need to be done on the sideline. I know that ocular motor tests were mentioned in the article. Could you please briefly touch on the other tests that would be helpful?
You'd mentioned the vestibular ocular motor screen, and that's one that's really started to gain some more evidence of late. It's also referred to as the VOMS, VOMS, and that refers to vestibular ocular motor screen, and this is to look specifically for vestibular ocular deficits after concussion. We know that up to about 60% of concussed athletes will have some type of abnormal vestibular ocular motor finding when evaluated. Whether it's problems with smooth saccadic movement of the eyes, or problems with convergence as they try to focus on an object that's coming toward them. And again, that's been incorporated, or at least a portion of that evaluation has been incorporated into the SCAT5. And that's just a good example of how the science continues to evolve. And these are things that we were not routinely looking at on a sideline evaluation 5-6 years ago, and now we are.
Thanks, great. And now we'd like to move on to our next article, but before we do, I want to take a quick pause here to let our listeners know that they can receive an exclusive discount on the issue we are discussing today by visiting us.elsevierhealth.com/expert. The third article we are going to discuss today is on sport-related headache by Drs. Sylvia Lucas and Heidi Bloom. The authors mention that headache is the primary symptom reported after concussion. but difficulty in estimating headache incidence is twofold. Could you please further explain that?
And I really want to commend these two authors, Sylvia Lucas and Heidi Bloom, both from the University of Washington. Both are just giants in the world of headache medicine, and I really appreciate their contribution that they made. Post-traumatic headache is challenging for a number of reasons. Without question, post-traumatic headache is far and away the most common symptom after concussion. 90 to 95% of sport-related concussions will report an associated headache as part of their symptom constellation. This is challenging for a number of reasons. We know that the prevalence of migraine, for example, is quite high in the lay public as well as the elite level athlete population. In fact, I just published a study earlier this year that suggested that the prevalence of migraine in elite level athletes is in the neighborhood of 23 to 24%. So this can really complicate the screening process in an individual with a pre-existing history of headache like migraine that then subsequently is exposed to head trauma and develops headache, because the question is, are they experiencing an exacerbation of their pre-existing headache disorder, or have they sustained a true concussive injury and they're now presenting with post-traumatic headache? And the authors, I thought, did a really nice job of highlighting these challenges and the types of screening that goes into an athlete of this sort.
Thank you. And I'd like to note to our listeners that Table 3 provides criteria to differentiate common post-traumatic headache types. Could you please describe how one determines the severity of a headache?
We know that from a phenotypical standpoint, or the clinical characteristics of the headache, the most common type of headache per clinical description after head trauma is still the migraine type. The headache that's throbbing, pulsating, has associated light and sound sensitivity, has some associated nausea, perhaps even some vomiting, has exercise intolerance. That's the most common type of headache experienced after trauma, the post-traumatic migraine. And furthermore, Anthony Contos' group at the University of Pittsburgh has done some good work in this regard, showing that the individual that experiences post-traumatic migraine, at least per clinical description, after head trauma, is a subset of athlete that is at higher risk for a prolonged recovery.
And speaking about the recovery, I know that you mentioned earlier that every U.S. state now has legislation requiring evaluation of possible concussion before an athlete can re-enter play. On top of returning to play, what should be considered when returning to school following a concussion?
There are a number of fairly routine things now that we will recommend, and these are what we term academic accommodations, especially for student athletes, whether they are youth level athletes or high school level athletes or collegiate level athletes. As they return to the classroom, that can be a significant challenge as part of their overall recovery process. And for these individuals, accommodations that are commonly recommended include shortened days initially as they return to the classroom, a reduction in workload, increased breaks or rest breaks throughout the day, potentially even delaying tests, or as they start to test again to give them extended time, or to give them tests broken down into separate sections. All of these can be quite helpful as an athlete returns to the classroom. And this is where it's really patient specific, because in some individuals, for instance, you'll have those that are still extremely light sensitive, so something like reduction in screen time or allowing them even some tinted eyewear to be used in the classroom is quite helpful, versus another individual that might not have those symptoms, but yet they're still just simply having problems with or challenges with prolonged cognitive exertion, and that's where potentially delaying tests for that individual or giving them extended time for tests might be helpful. It's really all patient specific, but usually to some level academic accommodations, at least early on after the injury, are quite helpful.
Thank you. And were there any other key takeaways you wanted to touch on regarding this sport-related headache article?
I just like the fact and appreciate the fact that they did touch upon some other types of headache. They touched upon contact-induced headache or contact-induced migraine, also previously referenced as footballer's headache. There is certainly a subset of athlete that can have onset of headache after exposure to contact or contact risk activities, and that's not necessarily a concussion. And the authors do a nice job of highlighting the differences there. There was also a reference made to exertional headache or primary exercise headache, those individuals that experience a headache simply with cardiovascular exertion. And again, that's very much different than a post-traumatic headache, and the authors do a nice job subsequently in that section as well, really highlighting the differences between that and how that's approached and how that's different than post-traumatic headache.
We would like to conclude our discussion today talking about your article on neurologic health in combat sports. When putting this article together, what were some of the areas you knew you had to cover?
Combat sports they're near and dear to my heart. I'm the chairman of the Kentucky Boxing and Wrestling Commission's medical advisory panel, and I also sit on our commission at large. So combat sport athletes are individuals that I see certainly on a weekly basis in my clinic, whether they're boxers or mixed martial artists. And the neurologic concerns with those athletes in combat sports are multiple. Obviously, there's the concern just simply of exposure to repetitive head trauma, and that goes without saying. But there are also newer issues within combat sports that do have certainly a neurologic health wrinkle, so to speak. That includes weight cutting, which is a very hot topic in the world of combat sports currently. We know that there's emerging evidence that shows that with weight cutting, invariably you can get a reduction in cerebrospinal fluid volume, and it's cerebrospinal fluid that serves as the buffer surrounding the brain to mitigate the effect of external forces imposed upon the skull or the brain itself. So weight cutting, again, is a very hot topic and seems to be associated on some level with increased concussion risk. Another topic that I really wanted to make sure that I was able to highlight was the effect of performance-enhancing drugs. Again, we've been aware in the world of sports medicine for some time the detrimental effects of performance-enhancing drug use, including anabolic steroids. But what I tried to highlight in that subtopic of the article was that there is good solid evidence now that shows supertherapeutic levels of testosterone, for example, can have harmful effects upon the central nervous system. Specifically, it seems to exacerbate the brain's response and the brain cells' response to exposure to head trauma, and seems to further propagate brain cells and neuronal responses to axonal injury after head trauma.
Can you talk about the importance of neurologists having an open line of communication with combatants?
I think that's a great question, and in fact, I can speak from my own personal experience, and I think I can also safely speak for some of my colleagues that are neurologists. We often get criticized for being involved in combat sports, where my response to that is always the following. I don't think that my involvement in combat sports condones the sport, but I also think that it's a bit reckless for the world of neurology and for neurosurgeons to simply ignore combat sports and pretend like they don't exist, because they certainly do. In fact, mixed martial arts is one of the fastest growing sports in the United States, certainly, and arguably worldwide. Whether we condone the sport or not, it's going to continue. So subsequently, I think having neurologists' involvement in the sport is only going to serve to help provide a healthcare advocate for those that are involved.
Thanks, and I think that's a great point. I wanted to direct listeners that we have a table displaying consequences of chronic traumatic brain injury in this article. Could you please discuss these components?
Correct. I believe you're referencing Table 1 in my article, Chronic Traumatic Brain Injury. Yes. And to give full credit, I adapted that table from Barry Jordan's article that he had written on brain injury in boxing, published in the Clinical Journal of Sports Medicine back in 2009. But this really just serves to highlight the spectrum of chronic traumatic brain injury that can be incurred with exposure to combat sports, and that goes from problems as severe and worrisome as chronic traumatic encephalopathy, which has gotten a lot of lay media attention of late, all the way down to persistent post-traumatic headache, which Dr. Lucas and Dr. Bloom discussed at length in their article.
Can you discuss the approaches for striving for the development, implementation, and enforcement of uniform minimum requirements for brain safety in combat sports?
When you really step back and look at the state of combat sports in the United States, for example, when you think of professional level sports, whether it's National Football League for football or Major League Baseball for baseball or the NBA for basketball, all of those entities have a specific, very clear and published guideline with regard to how they approach concussion assessment and management. They have their own specific protocol. Within the world of combat sports, speaking specifically now to professional boxing, there is no national governing body which has authority over the medical practice of concussion medicine within the world of pro boxing. And that's worrisome, primarily because this is a sport where the goal, the end point of the sport itself is to try to induce neurologic injury to your opponent. But yet there's no governing body that helps to provide any oversight with regard to management of traumatic brain injuries in this population of athlete. And that's an area that's a passion of mine, along with some others in the field. Barry Jordan I referenced earlier, Charlie Bernick at the Cleveland Clinic Lou Ruvo Center in Las Vegas. We continue to push toward having a more standardized approach with regard to concussion management in this patient population, and specifically within the world of combat sports.
Thank you, Dr. Seifert. Are there any other key takeaways you'd like listeners to be aware of in regards to neurologic health in combat sports?
The world of combat sports desperately needs sports neurologists to be involved, whether it's at a ringside or cage side level, or if it's just simply seeing these individuals on an outpatient basis in your clinic. This is a population of individual that the majority of these guys are not Floyd Mayweather and have immeasurable amounts of money at their disposal. These are typically individuals that come from a lower socioeconomic background, and these are individuals that desperately need healthcare advocates to provide their voice for brain health.
Thank you so much. We appreciate you taking the time today, and thank you for your efforts on this issue and for selecting a great team of authors to help shed light on this topic. We appreciate it.
Yeah, absolutely. I had a great time, and again, I sincerely thank every one of my authors that contributed to this. I thought they did a great job.
Thank you for joining us for this edition of the Clinics Review Articles podcast. For an exclusive discount on the issue we discussed today focusing on sports neurology, please visit us.elsevierhealth.com/expert. Neurologic Clinics is available for individual print subscription with accompanying online access, individual online-only access, as well as on the Elsevier electronic platforms Clinical Key and Science Direct. For more information on the series and our nearly 60 other titles spanning all medical disciplines, check out info.theclinics.com. Be sure to follow us on Twitter @ClinicsReviews and subscribe to the Clinics Review Articles podcast on iTunes and the Google Play Store.